Okay, well, everyone, thanks for being here. I'd like to welcome you to today's Apasa Cafe, our monthly colloquium featuring cutting edge Anabaptist scholarship. Thank you for joining us for today's presentation with Angela Kueny from Luther College, who will be speaking with us today about healthcare partnerships with plain people, providing support while conducting research. To begin, I'd like to thank Andrea Watzmunski, an integral member of our APASA Scholarship Committee. She is the one who manages the technology to make this event possible, and we are so grateful for that. For those of you joining us for the first time, please save your questions to the end of the presentation or put them in the chat. Our presenter is going to be speaking for about a half hour, and that should allow us plenty of time for questions and discussion afterwards. And if you do participate in the conversation after the presentation, your questions and comments will be recorded, and those recordings will be available to our members on our fabulous new website. So check that out. You can also access previous APASA cafes if you're interested at amishstudies.org. And if you're joining us by phone and would like to ask a question, you can unmute by pushing the star key and the number 6. So without further ado, I'd like to introduce today's speaker, Angela Kueny. Thank you so much for being here today and for sharing your work with us.
Thanks for having me. It's great to hear from you. So we have a small group on right now. Hi, Autumn. Autumn is from my neck of the woods. And welcome, Kelsey. As she said, there might be others joining, but I have personally really enjoyed watching past videos. So I'm happy to share the presentation with you today, knowing that maybe it will help other individuals as you move forward. So I'm going to go ahead and share my screen. Yeah, I was telling Natalie, I just think this is an awesome idea, this cafe, to allow people to just engage with each other. So Corey initially emailed me and asked, he said that he had read one of my recent publications and really enjoyed reading my methods and was thinking about possibly doing a sort of methods focused edition of the journal at some point. And so really broadly just kind of asked me to share some of my methods. And I started thinking that I've had different healthcare partnerships with Amish and Mennonite communities, and each of those I've done kind of different methods. And so I thought I would, for today, I mainly focus with genetic conditions, but to focus on methods that I have used with plain community families, working through the plain community systems, and thinking about community-wide assessments or partnerships. So first I'll do just a brief introduction of myself, and then we'll kind of dig in from there. So just so you know, I am a nurse, and so the lens through which I do research and learned about research and learned about my practice is as a nurse. And so my focus is mainly in the world of nursing. How do illnesses, illness and health, how does that fit into our overall holistic being? So sort of that partnership of the biological sciences and the social and spiritual and psychological sciences or portions of our body that we pay attention to. So working with the Amish for me really is a really nice fit. And I was trained at a liberal arts school as a nurse, and now I teach nursing. So I'm really embedded in the nursing world, but enjoy lots of interprofessional connections as well. But so Luther College is in Decorah, Iowa, and Decorah is, I just highlighted it, there we're actually sitting on a crater. So we're like, everybody thinks of Iowa as like really flat farmland, which is most of Iowa. But this upper area near the Mississippi River is called the Driftless region. And so we are actually, there's a lot of bluffs, and we sit inside of kind of a little valley here in Decorah, and it's really pretty. And there's lots of waterfalls, so I put the waterfalls. So we get to spend lots of time outside, which is wonderful. I have a picture in my presentation of the Amish communities, but Amish communities in Iowa and Mennonite communities tend to be sort of on the eastern side, but are kind of spreading Western. And as we were just talking before we started, it's Iowa farmland is really expensive, and farmers are growing larger and larger farms, which is kind of cutting out the small farmer right now being able to purchase farmland. So we're seeing lots of migration, sort of in and out migration patterns, but mostly on the eastern side right now. I'm also a mother of three, and wife to a silly engineer, and yeah, this is just a patch of the nursing program that I teach within at Luther College, which is a Lutheran institution. And I received my PhD from the University of Iowa. So my work with the Amish actually started with being a nurse at the University of Iowa in the Children's Hospital. In 2002, we had several families who had hemophilia, which is a bleeding disorder, come into our hospital. And I was an inpatient nurse at that time on the children's unit, and I was supporting the care of a 2-year-old who had been kicked in the head by a horse. They didn't realize he had this genetic bleeding condition. So they brought him in. And then we kind of unraveled that there was a lot of people in his home community with hemophilia. You need an injection, almost like an EpiPen. They carry factor. So if they are injured or if they have bruising, they need to inject themselves, and then they can form the clot that they need to form. But the genetic condition actually prevents them from making the clot that they need to make. And so you have to have the factor in order to prevent bleeding. And so as a group at the University of Iowa, we funded some initial just outreach clinics to go to families' living rooms and kind of do some education and figure out how are we going to build this partnership. And then we developed an interdisciplinary outreach clinic for the families. So once a year, so these are pictures of me with my nursing students now. When I was a nurse, and we still go with the whole troop from the University of Iowa, and we visit 2 different large communities, and just spend one day and see many patients in that one day. But it's physical therapy and social work and nurses and physicians. So we've been arranging these outreach clinics for years and years and years. And I started, so a lot of the partnerships that I have worked with Amish communities in this area have really branched from this initial service call that we had at the University of Iowa and partnerships with the communities that we serve. So I'll walk through a few of those projects here because they each have different methods because of the approach and the questions that we had. And so I'm happy to follow up with anybody on a lot more detail. Because I wanted to stick to that half hour, I'm gonna hopefully spend about 7 to 10 minutes on each of the methods that I used in three different projects, and then open it up for questions and discussion. I'm happy to share more when I'm finished as well. So just as a backdrop, so this is all housed within genetic conditions inside of the Amish communities. So a genetic condition is an abnormality in our DNA we've inherited from our parents, or they can arise spontaneously as we're born. And this is an example of a family picture. This is a recessive genetic condition where the mom and the dad both have to have it. And there are some conditions where only one of the parents have to have it. And there are some conditions called X-linked traits that mothers carry, and then the sons exhibit and the daughters become future carriers. So there are different types of genetic conditions, but in essence, you either inherit a condition or you have the spontaneous abnormal DNA at birth. Many genetic conditions are treatable. They can be screened for, and people live, long-term very well with them. Like hemophilia. Hemophilia happens to be an X-linked genetic abnormality or condition. But there are other conditions like cystic fibrosis that require treatment or can be fatal. And a very common genetic condition inside of the plain communities is maple syrup urine disease. and PKU, they're kind of in the metabolic disorders where if an individual consumes a specific amino acid, then they start to have failures inside of their body and cognitive abnormalities. And without treatment, those can also be lethal. And so some genetic conditions also don't have treatments and are lethal. So there's a wide range of genetic conditions, just depends upon the condition, the level of severity, the treatment focus for it. And so in the plain communities, genetic conditions are a particular concern because genetic conditions do originate and spontaneously arrive inside of the Amish or Mennonites or Hutterites. That is called the founder effect when they have originated inside of that group. And then they don't dissipate out because people typically marry within a smaller population. And I know it's a widely growing population, but it's a relatively small population compared to the entire world, which in the general population, people tend to marry people from a wide genetic pool. So because they're marrying within a focused population, that genetic condition stays there. And they are inherited. And so when you have large families up to 14 children, this picture starts to look like more people have the chance to receive that genetic condition and then carry forward to their future families. So these are the research so far inside of genetic conditions within plain communities, kind of these core elements. It's not necessarily because of the way they eat or their exposure to farmlands. And there's certainly some of those conditions that we'll explore, that are explored as well through the environmental impacts of DNA. But within the Amish, these are kind of the core attributes to why their risk is considered higher than the general population. Because the US Census and hospitals don't always collect religious information, it's really hard to have overall epidemiological data on Amish communities, but we know based on focus studies that its genetic conditions run at high prevalence. So the genetic conditions, there was a group in Canada who did a huge analysis in the early 2000s, and it kind of continued into the 2000 teens. And I'm not quite sure if it still is continued, but they keep track of, so they have a website that you can look up by disorder, by mutation, by clinical symptoms. And so you can look up the different genetic conditions, and then you can see whether it's in the Amish, Old Order Mennonite, Conservative Mennonite, Hutterite, so different groups and which category they're in. So we know that Amish families have genetic conditions. We have also been really focused on how are they receiving care. So different researchers have focused on the availability of care specific for genetic conditions. It's such a subspecialty inside of the medical field. It's very expensive. And then to be able to have specialty providers to be able to provide for Amish is also a concern inside of the healthcare community. And so as a healthcare provider, we are called to find ways to meet the health needs of this group of individuals inside of the plain communities. And so my work, I sort of thought about it in three different ways. I thought, because I've done different types of studies, some of those have been more focused on understanding the family experience, and some of those have been focused on working through the systems, the community systems inside of the Amish or Mennonite communities. And then some of those have really been like community wide. So I kind of broke it apart into those different types of projects. So when we were doing outreach clinics, we were noticing, we didn't really have any connection with the families in between our annual outreach clinics. And so one of our questions was, well, what are they doing in between their healthcare visits with us? What providers do they see? How are they managing their children with hemophilia? Are they taking different supplements? Are they using treatments? And so This project was just with Amish families because that is who we see, and that's the genetic line. Really interestingly, I took a sabbatical from Luther and I wanted to go out. I received a little fellowship placement at Elizabethtown College in Elizabethtown, Pennsylvania, and I was going to go hang out with the Clinic for Special Children and talk to their families with hemophilia to understand a little bit more, see the services that they provide in a standing clinic, to see how we could benefit. And I got out there and there were 0 people that they see with hemophilia. So it's not in the families in Pennsylvania, which I just found really interesting. I ended up working with PKU families in Pennsylvania. So I had a broader question, not just the families with hemophilia for this project. And this was part of my dissertation that then evolved into a follow-up study as well in my sabbatical. But the main question was how families manage their genetic conditions inside of their community and negotiating with the healthcare system outside of their community. So I chose an ethnography. I was funded by the NIH, fortunately, so I had the time and the space and bought out my nursing practice and my teaching time as a doctoral student. So I had the time to really embed myself with an Amish settlement. So I was doing interviews and participant observations and field notes. And as I mentioned, so the primary phase was part of my dissertation, and then I did a secondary follow-up just to see if the management strategies that I was witnessing in the settlement in Iowa was similar or different to families out east with really different backgrounds. And again, it wasn't just focused on families with hemophilia. I broadened the focus out to families with children with genetic conditions of any kind. And so during ethnography, you sort of spend some time hanging out, entering the field, and then engaging more deeply with the families with chronic illness management, and then finalizing analysis. So along my way, I met Sally Norton, who is actually also from New York. And she had a really great sampling plan, which is called case-centered cluster sampling. And so it focuses on a unit, and then it starts to interview and connect and invite people connected to that unit. So that unit that we talk about in this case, I was really focused on Amish children with genetic conditions. So I initially started reaching out to the bishops to partner for the project. And, as I was getting to know the community, other people got to know me. And being a nurse, fortunately, it's a very trusted profession. And so I was able to spend time with people at auctions and invited to come to school with some families. And I shucked corn with families and things like that, and just got to know different families in the community. But then I started, I wanted families from different districts. So in Amish settlements, they're broken up into districts according to their church district and their ministers. And so there were 7 districts inside of the community that I was working, the settlement that I was working with. And so I wanted families from each of those different those districts. And so my primary study was focused on diversity across the districts. And then the follow-up study was very similar, where I tried to invite families from different districts. And so in essence, what I did was I invited different families that I thought would be a good fit. We knew that they had genetic conditions, or they had reached out to the bishop. The bishops were my liaison. So I spent time with the bishops. They gave me kind of an initial directory of everybody, but they made the introductions to families. I met with all of the bishops first. And I brought my husband, and we just had an afternoon meeting about, their interest in this. And I still remember one of them saying, we need you in this community because sometimes we don't feel like we are respected when we enter into the biomedical system, and having somebody from the biomedical system describe what the experience is for our families will help to advocate for us. And their dream eventually, at that time, it was in the early 2000s, was to have a have a standing clinic nearby in their communities. And little did we know, the Clinic for Special Children was just getting underway out in Pennsylvania. So the dream has kind of carried forward to this day. The bishops were really inspired and connected me initially to the families. And so then once I spent time with the families, they identified who their caretakers were inside of the community and then inside of the broader medical community. So they had family members that were involved, maybe aunts, who, one family had an aunt who was an herbalist. Many of them listed an herbalist or a chiropractor sort of in their inner circle of daily go-to for who they seek initial sort of triage questions and help them negotiate what to do with different symptoms. And then each of them had either a primary care provider in the medical community or somebody, one of the specialty genetic providers that they were following up with regularly. And I saw different relationships between those specialty genetic providers. Some of them felt pretty close and supported. Providers who are willing to, make phone call or write letters instead of making phone calls, and would send a nurse out every once in a while to check on the family, just kind of go that extra mile, made a huge difference to the families, rather than, some of the specialists felt very far away and they just saw them once a year. Really, in between then kind of was the herbalist. But this sort of circular pattern, the case-centered clustering, allowed me to see how they were all connected together and how they were able to negotiate with each other. So during the study, we had a total of 12 participating clusters. And so I went into the details of the results in my publication from the primary and the secondary study. But sorry, I was just going to get my list of who was involved. So in the Amish families, parents and siblings, the child themselves and grandparents were kind of listed as some of the caretakers for families inside the home. And occasionally you would have somebody who happened to be an herbalist inside the family, so that person was handy. But inside of the community, what I discovered was this circle with Amish community members brought forward to me that there's really a whole healthcare system inside of the Amish network, and they have burn healers and they have specific herbalists, that do treatments in different ways. They have reflexologists, they have strategies to see different healthcare providers inside of the Amish communities, and reasons for seeing different people for different systems. And so it was really important to be able to identify that that is a sector of care for these families. And then the professional healthcare providers included nurses, nurse practitioners, physicians, pediatric and genetic specialists, dentists, social workers, physical therapies, and chiropractors who they were seeing. I included chiropractors in the healthcare providers just because of the difference in training. But I would say that most families viewed them as closer to a community member than a healthcare provider. And so I interviewed and spent time, went to appointments with families so that I could see it from the perspective of the family. Because I'm a nurse, I typically see it from the nursing perspective. And you can see the different diagnoses that I was able to see as well. So cystic fibrosis, hemophilia, PKU, nephrotic syndrome, hepatosplenomegaly, mental and cognitive impairment, a genetic condition that they felt was undiagnosed, and pediatric glaucoma. And so the usefulness of this specific strategy for collecting data, the methods in this case, also gave way to an analysis that was case-centered clustered, so I could do within case analysis and across case analysis. And Sally Norton also has a publication on that, and my dissertation chair Linus Ayres also has a publication on those if anybody is interested in digging into how to do analysis with this type of method. It was really fun and very eye-opening. But it really was able to unveil the Plain Community Healthcare Network and the models of care that were in that circle, but then also how families negotiated those circles with the biomedical circles, because they were all focused on the same child, for parents to be able to navigate and negotiate between those, was unveiled through this process, and also complications that they reached at each of the phases, which impacted some of their decisions about which one to see, such as financing healthcare. So that is a project that I did that was more family focused, really focused on what was happening with the families that we were doing. The next type of project that I engaged with this community is under sort of community outreach. We had some education that we needed to provide for the community, and an initial assessment of a concern that we had. So in this case, an infant came to the College of or the Children's Hospital at the University of Iowa, and was a newborn and was bleeding profusely, and was referred to the thrombosis center because they assumed it was hemophilia, and the infant was really deficient in vitamin K. And the vitamin K deficiency can be a genetic condition where they're missing the genetic clotting factor, but it also can just be that they are vitamin K deficient because they haven't received the newborn injection of vitamin K. So we focused on more of a community outreach model. The Minnesota Department of Health, Public Health, now is Health, identifies different strategies for community outreach. And so our lens was thinking of more of a systems approach to be able to implement and try to figure out how to get access to the women and infants to understand their vitamin K use, and then educate on how to differentiate, do you have a genetic condition that's going on, or do you have, are you in need of vitamin K injections, to try and avoid some of those emergency visits or some of those scares during delivery. So those steps are defining the community, identifying the health issue, organizing your team and getting to know your community, identifying your community partners, planning and implementing the activity, and then evaluation. And so I'll just walk you through kind of each of those steps here. So vitamin K is, we aren't born with enough vitamin K to support healthy clotting levels. And so infants who are born at home who don't receive vitamin K injections are at risk for bleeding. It doesn't mean they will for sure, but some of them have internal bleeding. And so there's a whole syndrome focused on vitamin K deficient infants and bleeding who are needing that vitamin K. And so we were strategizing, working on figuring out, is this an issue in this community? Are they receiving vitamin K injection? How are they receiving it? How many women are birthing at home? Some of those questions that we needed to work through. And then the complicating factor is this community is one of the communities that has hemophilia, which is a factor 9 deficiency in the clotting cascade. And that is also one of the vitamin K dependent clotting factors. So families with hemophilia not receiving vitamin K at birth are at additional risk for potentially bleeding, and working through the question of getting them screened as quickly as possible so that we can identify that as well. So again, we met with the bishops to try and decide, okay, how are we going to kind of go about this project to figure out how we can support mothers and infants in receiving education to be able to choose whether or not to receive the injection if they are doing home visits. So we were working with in a pretty focused Amish settlement. We were working with the local public health nurse who had a great rapport with a lot of the families. A local public health graduate student was leading some of the research behind vitamin K deficiency bleeding, and then physicians and providers at the Hemophilia and Thrombosis Center, and then me. So who we initially started working with, the bishop first sent us to the herbalist, and we had known the herbalist because of prior studies, but our prior projects and connections. And then the herbalist said, "We'll go talk to the midwives." And the midwives agreed that most of the births in the community were in the homes and that they did not intentionally get the mothers vitamin K for their babies. Mothers were taking oral vitamin K leading up to the delivery, but infants were not receiving it. And so then we started talking to the midwife and the herbalist about the possibility of receiving either an injection or oral vitamin K, and how then to distribute. And so oral vitamin K is really cheap, but it is not FDA approved in the US, although it is used widely. You can find it in, different studies from around the world. Mostly in Europe, they use oral vitamin K for infants at birth. So it's just a little droplet that goes into their mouth. In the United States, we do an injection typically. And so the difficulty of not having an FDA approved is that each of the supplement companies that sells infant vitamin K has different doses and different concentrations. And that gets really confusing if you're trying to figure that out in the home setting with a midwife, and which distributor are they using, and so on and so on. And so we ended up identifying this BioK emulsion as they were undergoing FDA approval. And so had the clearest instructions and concentration things. If the midwives felt like oral vitamin K would probably be the best way to start. So our next question for them, that in this project, we were hoping initially to have like little groups with mothers either pregnant or just had a baby and maybe they're still in childbearing era, about the vitamin K. And the midwives really felt strongly that this was they wanted to kind of own this education and be the connectors for the women. And so our education ended up actually being just with the midwives and then a few older mothers who had finished, but could give us feedback about, okay, what kind of education. We ended up creating a pamphlet so that the midwives could have it, and anybody could have it. We also connected to a nurse from a local obstetric clinic who was kind of the backup on call for the midwife, to see if she would ever be available to come out and do injections, so that if they preferred the injection, the midwife could also, or if they were coming out for something else, they could come out and do that as well. So what we ended up doing for this particular project is working through the midwives. And then some of the families were seen by the public health nurse if they were receiving screenings, or the local physician office, the chiropractor. We ended up distributing the pamphlets and the oral droplets, and the home visit, possibility of home visit injections through the visiting nurse through the systems that met with the mothers. So we never actually met with the mothers, but we just worked with the systems that got them in place. So we followed up a few months later, and they were distributing flyers and things like that, and women were open to it, but we didn't actually get access to the actual mothers. So that's kind of an example of sort of a systems approach that we ended up using. And my final example is engaging in sort of the whole community-wide, more of a broader epidemiological project that we had. And this was inspired by the work that I did out east with Dr. Morton. I spent some time with his clinic because of the work that I had done with families in Iowa. He wanted me to do the same thing with some of his families to understand, who are they seeing, because they're not seeing me. Can you help figure that out? So he wrote a series of lectures or essays called Roads roads taken. And they're really beautiful, and his daughter is a painter, and so I just wanted to share this as one of his inspirations, the death of Enos Fisher, for the work that Dr. Morton does. So Dr. Morton created a model of healthcare clinics in which he is a geneticist and built a clinic on the corner of a farm. And it's run by Amish board members, fundraised by Plain communities, Mennonite and Amish. The first one was outside of Lancaster County, and now there are 8 across the United States, across many states. And so we were really inspired by that. And one of our questions was, well, I wonder if we should have a clinic in Iowa and maybe Minnesota, something that can meet the needs of all of the genetic conditions across these states, because the closest one to us is in Wisconsin. And his quote that has been really inspiring: "These special children are not just interesting medical problems, subjects of grants and research, nor should they be called burdens to their families and communities. They are children who need our help, and if we allow them to, they will teach us compassion. They are children who need our help. If we allow them to, they will teach us to love. If we come to know these children as we should, they will make us better scientists, better physicians, and thoughtful people." And so we carried forward with our mission, just really thinking of how can we get to the most amount of children now that we know they're there. So this is the first clinic. Now they've built a different clinic. They've outgrown it. There's Dr. Morton in the corner there. And he now runs a different clinic up in central Pennsylvania. So we started thinking about how we were going to assess the genetic needs and genetic conditions across Iowa and Minnesota. We started with Iowa because we know Iowa a little bit better. We started it, unfortunately, in the fall of 2019. So speaking of COVID kind of paused our research for a while. But the intended focus was to get as many of the Amish and Mennonite settlements and larger groups across Iowa and Minnesota. So we used the Raber's Almanac to identify bishops, and we developed the survey and got feedback from the bishops. The survey that we used was used by one of these very similar clinics in Kentucky that asked about diagnosed, undiagnosed genetic disorders, undiagnosed medical disorders, and deaths in the household. So we developed the survey and then started to just meet individually with the bishops to try and strategize, how are we going to get this survey to as many households as we possibly can without going door to door to every single person in the Raber's Almanac. So the estimated population of Amish in Iowa is 9,780. Minnesota is 4,740. So I know it's much smaller than some of the East Coast settlements and states, but because of that, a lot of the communities are really disconnected and isolated. So they're even at further increased risk, which adds to the reason that we would want something central that they would be able to access. Plain Mennonites are unknown, although we think that there are a little less than 1,000 Old Order Mennonites in Iowa. So what we did was we met with the bishops, revised the survey, and we just individually, I had a partner in crime, Lee Zook, who is he had left the Amish community, became a social worker, and happens to also be at Luther. But we worked together to contact and personally meet with the bishops of the larger settlements of Mennonite and Amish over a 3-year period. It took us a long time. And what would happen is then the bishop would identify a minister or a school teacher or somebody on their hospital board who would distribute the surveys themselves. What we found worked the best, that I'm surprised they did, but they did. They handed them out at their church service and said, bring them back in 2 weeks. So that was probably the highest rate of return for us. The school teachers also handed them out to the kids and had them bring them back, gave them a due date to bring the surveys back. So that helped us, I think, with our survey data. And so then the families received the survey, they completed them, whether they have a genetic condition or not, because of that question of undiagnosed. They gave it back to their point person, and the point person bundled them all together and mailed them to me and Lee. And single surveys, some families individually kind of mailed them back over time. And so I just share this. We will be publishing, hopefully, in this journal, the results. Now we've gotten to the Minnesota districts and received those surveys, and we're just in final analysis of that. And but you can see that these are some of the major districts, and the percentage of the population who responded is very high for survey data. So it's pretty impressive response from the communities. But I think those initial, in some of the communities, the bishops invited a large group to hear us talk about the genetic surveys and the purpose of doing them, which is to potentially have a clinic that could serve the communities in Minnesota and Iowa. So I think having a shared purpose was really helpful. And I think taking the time to go meet with as many groups as possible from the communities were really helpful, so they understood who received the data and who was going to be, how we were using it and what we were going to be doing with it. So over the course of that time period, we made strong enough connections with some of the communities that we developed a board, and we'll hopefully be initiating one of those standing clinics that will be able to house and focus on genetic care for the conditions. So we received kind of the type of genetic conditions, questionable, undiagnosed genetic conditions, and we think that there are at least 40 or 50 known genetic conditions across Iowa and Minnesota that need to be addressed. So it was a really helpful survey, and this was a really helpful method in order to be able to receive as much information from the communities that we are near. So that is the end of my presentation, and we continue to advocate for innovative models of caring for Amish communities. And I think by being able to have different projects that focus on individuals or family needs and working through systems to be able to implement projects and then community-wide projects, we really have been able to use our methods to meet the needs of the different projects that we've had.